Welcome to pulmonary function testing for pediatrics and infants. This is based on Chapter 16 in Walsh. Pulmonary function testing, or PFT, is an objective measurement of the respiratory system under various conditions of normal, disease, and stress states. Pulmonary function measurements can be used as a primary diagnostic tool or to frequently monitor disease progression by comparing previous or subsequent assessments. PFT results corroborate a diagnosis suspected from other things in the pulmonary respiratory assessment, primarily the patient history and physical examination. The American Thoracic Society and European Respiratory Care Society, ATS and ERS, publish standards and guidelines for testing system performance, characteristics, quality control, and test methodology for children that are preschool aged and adolescents. The American Thoracic Society and European Respiratory Care Society have standards that they publish for preschool-age children through adolescence. It's important that for quality control and for test methodology and performance characteristics, that these guidelines and standards are adhered to. The Pulmonary Function Laboratory Equipment Quality Control Program needs to follow these recommendations and ensure accurate test results regardless of the size and age of a subject being tested. Assessing whether a specific measurement is normal may be complex because of a wide range of variability in normal children. Recent reference equations have been published for spirometry, diffusing capacity, and other variables that help define lung function in pediatric patients. An all-age reference equation was published in 2012 by the European Respiratory Care Society Global Lung Initiative Task Force and defined normal values for common spirometry indices down to 3 years of age. PFT measurements include bedside measurements with a bedside spirometer or through the ventilator. Lab measurements using a body box or full spirometry system. Things to consider when working with children and doing a pulmonary function test. The disease process. Does the child have asthma, cystic fibrosis, scoliosis, or CP? Cerebral palsy. Will they be able to cooperate? How sick are they? Are we doing this for monitoring? Then we have to consider the age. We can do pulmonary function testing as early as 3 if the child is cooperative. However, a general rule of thumb is 4 years old is better, and it's best with an 8-year-old or older patient. Equipment must be properly sized. Chairs must be at the right height for a child, and the child needs to be able to understand, without being upset, how to work with the equipment. Respiratory therapists should be specifically trained and obtain their certified pulmonary function technologist or registered pulmonary function technologist prior to working with children. Creating a safe and fun environment for a child will help get the best test results. Why do we do pulmonary function testing in children, you might ask? Well, one is to diagnose or to quantify the severity of their disease. Another is to monitor chronic disease, such as asthma. A third reason is to see how effective our treatments are. Are the drugs we're giving working? Are they getting year to year? Do we need to change medication or medication routine? And then pre-op planning. Even children have operations. Tonsillectomies, repair of a compound fracture are fairly common in the pediatric population, and we want to see how well they breathe before going under anesthesia. For our purposes, we'll define spirometry as flow volume or flow time measurements of basic lung function parameters. Spirometric measurements include forced vital capacity or FVC, forced expiratory volume in 1 second or FEV1, ratio of FVC, forced expiratory flow at 25 to 75 of vital capacity or FEF 2575, and forced expiratory flow at 50% of vital capacity or FEF 50. Lung volumes are described as measurements of thoracic gas volume, functional residual capacity, residual volume, total lung capacity, and the ratio of RV to TLC. These can all be done with a body box or body plasmography. Diffusing capacity of the lung for carbon monoxide or DLCO is important to look at how much the body needs oxygen, which we can also do with body plasmography. Spirometry is a common test performed on children and requires active participation and cooperation to get acceptable and repeatable results. Spirometers come in two general types, volume or flow. However, flow-based spirometers using a pneumotachometer or other sensors for flow are much more common, smaller, and easier to integrate into a system. Some of the important measurements with spirometry are FEV1. Normal is 80 to 120% for a child. FEV 1 to FVC ratio. Normal for a child is greater than 70%. Total lung capacity, seen in plasmography, 80 to 120%. And residual volume, 80 to 120%. Other things that we might measure at the bedside. Vital capacity. Vital capacity uses a small meter for a child to blow into slowly and steadily their entire breath. This is particularly useful in the case of neuromuscular disease. Peak expiratory flow rate can be done with a bedside spirometer, but also can be done with a peak flow meter. This is especially useful in asthmatic children over the age of 8. Or negative inspiratory force manometer, MIP, MEP, NIF, or as we said, negative inspiratory force. Negative inspiratory force tells us how well the diaphragm is working. Peak flow rates in asthmatic children. Notice that peak flow rates are based on height. not on age or sex for children. Pulmonary mechanics look at gas movement in and out of the lung, such as tidal volume in millimeters inhaled and exhaled during each resting breath. Often, tidal volume is compared to a person's body weight and reported as millimeters per kilogram of body weight. Some PFT systems report inspired and expired tidal volumes separately. Others combine the two. Typically, an average of at least 10 resting breaths is a better method of reporting tidal volume. Other pulmonary mechanics include looking at the elasticity of the chest wall and lungs, resistance in the airway, and the action of the respiratory muscles. These include lung compliance, such as dynamic and static lung compliance, and pressure flow and volume over time. Bedside spirometry. Spirometry values are commonly used to determine whether a disease has a restrictive or obstructive component. Flow spirometers, such as pictured here, are lightweight, easy to use in a medical office or at the bedside. Spirometry values are commonly used to determine whether a disease has a restrictive or obstructive pattern. Most common chronic diseases in children, asthma, cystic fibrosis, and bronchopulmonary dysplasia, are obstructive. Obstructive diseases produce a concave shape or scooped-out flow volume loop. Most restrictive defects in children are related to abnormal chest wall configuration or neuromuscular weakness. Caution must be used in describing restrictive and obstructive lung disease on the basis of spirometry alone, because complete lung volumes are not measured. If a child did not take a deep breath, the FVC will be artificially diminished and mimic a restrictive pattern. Therefore, the therapist should consider performing one of the lung volume studies described next in order to preserve flows and look at a visual pattern. Obstructive versus restrictive. In obstructive disease, which is most common with children, your forced vital capacity can be normal, the volume, or diminished. The FEV1 is generally decreased. The FEV1 to FVC, decreased. The total lung capacity, either normal or increased. The RV, the residual volume, is increased. Shows how much air trapping there is. And the residual volume to the total lung capacity is usually increased. Restrictive patterns are less common with children. Children with neuromuscular disease may have a diminished forced vital capacity, a diminished FEV1, a normal or increased FEV1 to FVC ratio, a diminished total lung capacity, a diminished residual volume, and either an increased or a normal residual volume to total lung capacity. What was pulmonary function testing like back in the day? This is a common bedside spirometer used in the early 1900s. Lung volumes and capacities, helium dilution method, nitrogen washout, and plasmography all give us standard lung volumes. The helium dilution method of calculating an FRC measurement measures only the gas that is in direct communication with the central airways. Helium dilution is described as a closed-circuit technique because the subject rebreathes within a closed system, typically a bag. This technique uses the principle that the concentration of a gas in one volume is proportional to the concentration of the same gas in another volume, provided there is no production or consumption of the measured gas. Therefore, knowing the concentration of the gas inside the lungs and outside, as well as knowing the external volume, allows calculation of the lung volume, done in a body box. Nitrogen washout method of calculating FRC also measures only the gas that is in direct communication with the central airways. However, nitrogen washout is described as an open circuit technique because the subject's air is measured and expelled from the system. A child breathes 100% oxygen up to 7 minutes with a mouthpiece which displaces nitrogen in the lungs. The circuit must have no gas leaks, and the system measures the volume of nitrogen washed out of the lungs. Body plasmography requires that the patient sit in an airtight acrylic glass box, commonly called a body box. There are 3 types of body plasmography: a volume, flow, and pressure. The most currently available body boxes are those of pressure, which uses a constant volume, pressure variable technique. During constant volume body plasmography, the child voluntarily pants against a closed shutter. Using Boyle's law, the change in pressure against the closed shutter attached to a tachometer is used to calculate a volume measurement, the TGV. The TGV is measured at a known FRC value rather than on the basis of assumed values. Total lung capacity, the inspiratory capacity, is obtained by spirometry and added to the FRC. To calculate the RV, the expiratory reserve volume is subtracted from the FRC. In addition to measuring lung volumes, body plasmography measures resistance and specific conductance. Volumes and capacities. A volume, if you remember, is a single value. A capacity is 2 or more values. You can see inspiratory reserve volume, tidal volume, and residual volume are all a single value. Common spirometry programs used in pediatrics need to be child-friendly. In this first case, a child blows a sailboat over to an island. And then in the other case, a child helps to move a fish along by blowing out. Spirometry results in pediatric pulmonary function testing look similar to this. Let's talk a little more about a pediatric body box. As you can see, The seat is active and adjustable. It's comfortable. There are stickers on the outside and on the inside to make a child more comfortable while they're enclosed in the body box. Thank you for listening to this lecture on pediatric pulmonary function testing. And remember, when you begin with the end in mind, you'll always know where you're going. Thank you. The end.